And since all the attendees are our routine attendees, I would say, or periodic attendees, I would skip the introduction part and will directly go to today's topic, which is how to add value to healthcare. And I want to give you a little bit of prologue why I chose this topic, and then we'll go for the case, and then we'll have our attendees share their thoughts. So when I started my training, we were so much hardwired for evidence-based medicine, where whatever we do, we try to find scientific evidence for it and try to analyze it to the very best possible scenario which is applicable to that particular case, and then you apply that form of medicine. So it was evidence-based medicine in true sense. Sometimes it sounded very idiotic, but we still did it because we played by the books. And I came back to India, and it certainly seems to be that not any particular mode of so-called based medicine is the way to go. I think that there has to be a fair balance of everything that we have got in terms of evidence, in terms of what is common sense, what is experience, and whatnot. So I heard the term called eminence-based medicine, where you try to learn from what your seniors have done and gain experience from them, and then try to incorporate those. And obviously, if that conflicts with the evidence, then you have to come up with a middle ground. But I did realize that in India, we are a little bit less rigid in terms of following that evidence-based medicine. Now, apart from evidence and eminence-based medicine, in the last decade or so, there has been this new thought. It's not new in any sense, but it is picking up in the last decade or so, the so-called value-based medicine. And essentially what it means is when we talk about patient-centric healthcare, then in that scenario, whatever we provide in terms of therapeutics or procedure or whatnot, there has to be a perceived value to the patient whom we are providing. If the patient or the recipient of the therapy does not perceive value, then no matter what evidence or what eminence we are applying, that may not be that advantageous, as to speak. So this whole value-based medicine has crept in the last decade or so. And if we think more about it, it does not conflict with our current evidence or eminence-based medicine. It essentially is just an extension of that. I will share with you a very funny anecdote, or curious anecdote. Repatha, which is a PCSK9 inhibitor, that drug, as we all know, is used for hyperlipidemia, and it is there to for primary or secondary prevention of ASCVD. The drug is very costly. Very costly means it is cost prohibitive even in markets like US and Europe. So Repatha came up with evidence that it does help in the clinical outcome and whatnot, but still it was not enough. So recently, this whole thought came that if you are giving such a costly drug to the patient should perceive value. So if patient gets an event while being on that drug, then what happens? Then the whole value structure fails. So Repatha came up with this so-called deal, as to speak, that if some patient who is on Repatha gets an ASCVD event, then whatever that patient has paid for Repatha up to that day, Repatha gives 100% rebate to that, so that at least patient does not get a financial burden of that costly medication that is giving. So that was a change, that an example that I gave you in terms of adding value to patient's perception. Now, we may agree or disagree with it, but the idea remains constant, which is how to add value, or at least perceived value, to our patients. And it doesn't have to be big events like acute MI and whatnot. We're talking about routine encounters. Like, I'll give you an example. There was a patient who came to my OPD with chest pain that happened one day before. Currently asymptomatic. He just thought, let me check it out. He came to me. I thought it was angina. ECG echo is normal. The guy is currently asymptomatic. His troponin is hugely positive. He's otherwise stable. He's fine. He's like, doc, I don't have any problem. So I gave him some medications in the OPD, gave him a shot of low molecular weight heparin, told him to get admitted in the ICU for observation. And as a good patient, he followed whatever I said. He went to the ICU, he's admitted there. Now in the ICU, his oxygen is fine, so he's not on oxygen. His blood pressure is slightly on the lower side. They're not giving him any infusions. He already got a low molecular weight heparin, so he doesn't need an infusion that way. So he's just sitting in the ICU chilling. And he's thinking that probably my doctor knows better, that is why he kept me in the ICU. But he's not able to perceive the value of why he's in the ICU when he's otherwise feeling okay. He doesn't have any problem. I'm not giving him any IV drug, which is in a perception that he's getting treated. I'm not putting a mask or oxygen on him, which is the quintessential treatment in ICU. Just for blood pressure check every hour, he's not able to perceive that value that I have told him, that you be in the ICU. I'm practicing evidence-based medicine. I'm practicing what is correct for him. But I'm not able to, or my patient is not able to perceive that value. So there are lots such interactions which we have in our daily life where it becomes very difficult to add that value, provided we think about it. A lot of the times we think that our evidence-based medicine is good enough, or our experience-based medicine is good enough, and if we are doing things right, we don't have to think more about it. And that is what I want to challenge. I think we should talk more about it. We should think more about it, so that how to add value to our patient perception. So with that prologue, I'm going to add today's case. And in today's discussion, we can off the record of what we do. So Praneeth, here is the case. This patient I saw last month. So he's a 62-year-old male. He came for routine follow-up. He lives in Nizamabad, which you know is about 200 kilometers from here. He's asymptomatic on the index follow-up. The way I know him is because last year he got admitted under me. He had an evolved inferior volume at that time. And I did a late PCI, kind of a rescue PCI on him. His LV recovered, otherwise he didn't have any other problem. He has got no comorbidities as to speak. And he's otherwise pretty good. I saw him 3 months ago, and at that time I got his labs and echo and everything checked, and that was okay. He didn't have any problem. So this time he came after 3 months follow-up. This is his 1-year anniversary of the disease. And this time I didn't do any investigation because 3 months ago investigations were okay. So he comes to me, he says, Doc, I'm feeling fine, I'm okay, I'm taking all the medications regularly. He checks out in terms of any side effects or anything, that is all fine. So I essentially tell him that, you are stable, doing fine, go home, continue some medications. So the interaction pretty much lasts for 3-4 minutes. Now what I'm thinking is, this is a guy who came from Nizamabad to see me. He takes a bus to come here, which is about 4 or 5 hours on the bus. He comes and sees me, and for obvious reasons, I'm not, or any doctor is not directly accessible. They typically wait for an hour or two with the registration and whatnot. By the time they go home, it's another 5 hours. So total, they have spent 13-14 hours to see me for a 5 minute, less than 5 minutes interaction where I say everything is fine, go home. And I'm thinking whether this patient got the value that he perceived, that he thought he's going to get. So Praneeth, my question to you is, in this particular patient, and please feel free to take other examples, how to add value to the care that you are providing. And it is with regard to the patient's perception for the value, patient's perception of the value for the effort that he put in to get that health care. So Praneeth, take it from here.
Yeah, good evening everyone. So definitely a routine scenario, Anup. I'll give my perspective of how I see my patients and probably add into your case as well. I believe that every doctor interaction is an experience which I think, and that experience is something which he remembers. And I want that experience to be as fruitful or value added as I see. So what I do, in addition to what you already mentioned, try to make that experience comfortable, where I also add in some general open-ended questions, in the sense, how are you doing, how are things back home, and other things. In addition to the specific questions in relation to cardiovascular system, I also talk about the daily essential things kind of a thing where are you sleeping well, are you eating well, your appetite is okay, your bowel and bladder movements are okay, and how is everything, and give him an open question, is anything else that you would like to ask, or how do you look into it. This way, most of the things which I feel is we are in a rush, and I feel we don't give enough time for the patients to get his questions answered. That is where I think if we can give him an opportunity to answer all his questions, whichever he has, probably in that way his visit, I believe, is kind of makes any sense. I also encourage my patients to get their questions noted and ask them in their visit, because most of them tend to forget their questions and they feel that they forgot and wish they would have asked. So these are two things which I encourage, so that this is what my way of giving them value. Coming to the question that you asked about this patient who had an evolved inferior MI coming for follow-up, other than optimizing medications which he is already using, so-called reaching the targets, educating him about what are the targets that he needs to do into this thing. Probably one thing I can add is suggesting him about vaccination, because he has an ASCVD about vaccination for the influenza, pneumococcal, and the current COVID-19 vaccination to prevent secondary infections, and give him some education or importance of secondary prevention of ASCVD. This is what I can think of it right now.
Thank you so much, Praneeth. So what you said in terms of, like, we are all in rush, and so many times we don't know or we are not able to so-called add value or whatnot. I gave an example of this particular patient who has certainly put in extra effort, but when the patient comes to your OPD, you don't know the kind of effort that patient has put in. So the question here is, rather than being selective for few particular patients, is there a way we can systematize our clinic visits or their OPD visits, so that like a patient seeing a dietitian on routine, or patient seeing somebody else on routine, so that they think some value is added. So let me continue this discussion. I will ask my other attendees to share their thoughts. Dr. Praveen, you heard me asking about how to add value to patients' experience. If you don't mind sharing your thoughts, you can take any patient scenario or the one that I gave you. Dr. Praveen, if you could unmute yourself.
Good evening, everyone. Sir, from my perspective, what I would think is whatever the patient, whoever is coming in search of a doctor, the experience, whatever he feels during that interaction with the doctor carries a lot of the effect on the subsequent visits. So even we do not know how much effort he has kept to come for that particular visit. We should be allotting a few minutes to interact with him, even if he says everything is fine at that particular visit. Say for example, we have seen a case of acute MI. He underwent primary PCI and he is under follow-up, or he is receiving medications under Argyasri, which after 1 year he would be not receiving the medications which are provided free for him. I am saying from the government perspective. So after 1 year he has to spend money from his pocket. So until that particular point of time, he has received the medications free, which are being paid by the government, and then the next visit he should be paying himself. So knowing your patient, as the visits go on, is very important. Probably because the financial burden, he might be the only breadwinner of the family. The financial burden that would be taking for the medications he has to purchase, that all should be known, and if we could see any other alternative that he can visit a what you call nearby hospital just for routine medications follow-up, that we should be able to see. I would be doing the same thing, because if the same patient is coming along a distance of 300 kilometers to see me at Usmania, I would say them to have the same medications at the nearby government hospital. Only in case of emergency they can contact me and come in wise, so that they can save the money in transport for the medications to purchase at them. Similarly, another case scenario which we face the issues is those patients who are on prosthetic valves. They come for the what you call a follow-up every 1 month, just to have PT-INR value. This is again from the Usmania perspective I am saying. They just come in the morning for the PT-INR. They get the test done at the GE department. They bring the value, and they will be having only 2 or 3 medications, acetylene, digoxin or anything. After that, we'll just see the value, we'll adjust them, and they will go away. But they will be coming only for the test, traveling a kilometer of almost all 200-300 kilometers. Just based upon the PT-INR value, will be adjusting the dosage, but will not emphasize what is the cause for the decrease of INR value, or why it has been increased. Is it just a what you call overestimated value or a underestimated value, whether there is any drug interactions or not? Most of them, because digoxin and amiodarone can also cause the change in the INR values. But in subsequent visits, if the patient lands up in trouble and come, then we think that we should have seen that particular drug interaction. The third scenario would be a rheumatic heart disease patients who come with for the penicillin prophylaxis. Just for the white color injection, which we call, they come from a long distance, and after the injection they will be going. Most of the patients will be coming with complaints of pain in the gluteal region and all that. So allotting time for the patients, knowing our patients, and seeing their problems, allotting some more time would be beneficial, sir. I think that would be my take home.
So, Praveen, few things you mentioned, I think those are fascinating, and at least one of them is new for me. So I did not know that Arogyasri patient gets medicines only for 1 year. After that, they pay out of their pocket. That's a good information to know, at least to me, and if anybody who didn't know this information before. So that can be arranged. And of course, that way you add value, because you know something that either patient does not know, or maybe some other doctor does not know. So when patient comes to you, getting that knowledge itself certainly is a value addition. There is no doubts about it. And then one thing that you mentioned about long distance patients seeing their local doctors. So I'm guilty of that. There are times when I see these kind of patients whom I personally feel that if I'm not adding much value, then I myself tell them that, you coming and seeing me, particularly for this, I'm not adding as much value, an incremental value compared to a local doctor near your town. So it may be better for you to see them 3 monthly that you need, and then maybe come and see me once a year, or just do a video call or something like that, or come as needed basis. So that way, I can justify my face value to him. So those are important. And then the third one about PT-INR that you mentioned, I remember in US we used to have Coumadin clinics, also in the same aspect, that you realize for a patient to visit a doctor only for INR assessment was probably not adding enough value. So they had a nurse-run Coumadin clinic or warfarin clinic, where patient would directly interact with the nurse over the phone or whatnot, so that they get the value worth from the patient, from the nurse, and not spend that much time, energy, and money coming to a doctor just for that INR value. In India, if we can have something like that, or if we can have a home-based assessment, something like, you have a home device or something which patient can just get a check, which is accurate, most important, And then that value can be discussed with a nurse or with somebody or a doctor over the phone. So that way, appropriate value is added for appropriate therapy rather than them coming all the way to the doctor's office and spending all the time and energy. I can imagine it's not easy. These patients, they spend a lot of time, energy, effort, sometimes wait for doctor for 3 hours just to say that, your warfarin is okay and take the same dose. So I concur a lot of what you said, and I think that does give us discussion points. Let me get forward with my attendees. Dr. Shankar, if you could share your thoughts on this, I'm sure that you have far more patient experiences like this to share than us, particularly in the physician world. This is very important, how to add value to the patients. Dr. Shankar, if you could share your thought, please.
Good evening. Good evening to all. Thanks to Dr. Anup Agarwal for giving me this opportunity to share with my thoughts on this to this August audience. Earlier, the doctors and patients were treated as a god and devotees. The relation between the doctor and the patient was a god and devotee. But now, almost there is an uproar in the society that the medical facilities have become commercialized. So a good physician, he treats a disease. A great physician treats the patient who has a disease. William Osler's words, these are. So as a great physician, we have to think of how best we can provide value-based care with a lower cost, so that we will be again treated as a God. We will be regarded as equal to God. Vaidyo Narayano Hari, the ancient epics, they tell us. So how best we can provide this value-based care with the lowest cost. Few points I want to, which have come to my mind. One is, in this pandemic era, every physician has got an experience of teleconsultation or virtual consultation. So we can save time of both the patient and ourselves also. When we are busy in the clinic also, so if you give him an appointment to see him on mobile in the evening, 5 o'clock, 7 o'clock or the 8 o'clock, so we can speak to him at a leisurely basis. Why I am telling, nowadays the smartphone is available with even a common man. The mobile phones are more than the toilets in India. 1.3 billion population of India has got 1.5 billion connections of mobile connections, and 1.7 mobile pieces in India. This is the world's Guinness Book of World Records. So we have to use the modern system of the modern gadgets to provide teleconsultation or virtual consultation. Is one point it has come to my mind, because the smartphone is available with anybody. Even if the patient does not know how to operate it, the schools, malls, halls, everything is closed now. Everybody is at home. The children, students are at home. They are well versed with the new gadgets, so they will better operate this smartphone, and they can reach the doctor concerned. And the second thing is, in the value-based care, we have to provide some managers, so that they will discuss regarding the disease, regarding the health package and all these things, the economics, how best we can help them. And third one is, even in our diabetic clinic also, we will have diabetic educators. So dietitians will be there. So likewise, if we can get access to the dietitian also, who explains the friendly diet for the improvement of his health, and at the same time, a social worker team here in our Jagityal, we have appointed Arogya Rakshaks. They will take care of our health. So there are service volunteers. See, because I belong to one organization, Seva Bharati, it's a service organization of RSS. So we have provided Arogya Rakshaks here. They will take care of, during the pandemic, they worked a lot. So these health volunteers, they will guide the patients. They will consult the doctors. They will consult the lab people. They will consult with the ultrasound people. They will consult with the radiology labs and all. So, and they will bargain for a better price to get it done at a lower price. And third one is the uproar in the patients is the costly medicines the doctors are writing. Even at 1/4 of the price, these drugs are available in the Jan Aushadhi. They are so-called famous as Modi shops. So where we can get the generic drugs, and we can show it to the healthcare workers or primary healthcare physician, whether it is a good company or not, whether it works or not. So even I'm surprised to know the drugs like Januvia, which costs more than 50 rupees in the market, is available in the Jan Aushadhi at a cheaper price. So I suggest my patients to purchase Jan Aushadhi or generic drugs. And one more suggestion to the corporate sector, because corporate sector is already they have been doing a lot of service by telemedicine. I know Dr. Somraju sir here, Dr. Krishnamraju sir and others, they have through CARE Foundation and the Bairaju Foundation, they cover more than 200 villages near Bhimavaram, and they provide very good health care. So here also the corporate sector, at least if not providing this mega health camps or taking care of the patients there by lot in the villages, at least tie up with the local primary care physicians, and so that the primary care physician is a liaison officer or liaison between corporate and patient, so that patient will get a value-based health care. And lastly, I suggest most of the patients, they pay from their pocket. But health insurance, even health insurance facilities are there. Most of the patients, they don't know. At least as a social worker or a nurse care manager or anybody as a primary care physician, we should help how best he can get health care insurance. Though I am 65 plus, I am not allowed any insurance company to join in. So during the pandemic era, if I get the COVID infection, I have to shell down around 20 lakhs. Some few patients were paid in my area. So for that, I consulted one Star Health Insurance. They allowed me to join in their health insurance, though I am 65 plus. So that way we can utilize the services of health insurance to get the cost come down to the patient. And lastly, this is quite important. Just now I told that Swami Vivekananda also told there are two things before us. One is service and then is sacrifice. So a doctor is a Vaidyo Narayano Hari. When he is equal to God, he has to give some service to our patients. Barefoot doctor philosophy is there in China, where the qualified doctor, they go on a bicycle to each house and find out what the disease is. Earlier also, 40 years back, we used to have malaria workers. They used to come and inquire. Nowadays also, so many systems are there, but they are not working. They are almost failed. Only they are working for only salary, but not service. So, we should conduct some mega health camps with a full equipment, at least with ultrasound and portable X-ray machine, good labs, and with the paraphernalia, along with a doctor's team. And we could go, if we go to the villages or headquarters also, we can provide service to them. At the same time, we can give suggestions to our own patients, those who have attended our own corporates. So they are not able to attend our again coming to Hyderabad, it's a problem to them. Just now, Dr. Praveen has enumerated so many examples. So to fill this gap, I request the corporate doctors to come along with the paraphernalia and a good healthcare team and provide services. Dr. Somraju sir is known for that. He is felicitated even in Satyasai as the best doctor with the Lifetime Achievement Award. He got Padma Shri also. And one more thing I will tell and stop. Dr. APJ Abdul Kalam. I attended a meeting of IAN, that is Indian Academy of Neurology in Delhi, conducted by Dr. Mahindra Ratta. There, Dr. APJ Abdul Kalam, former president, no more now, he is late. So he attended that meeting as a chief guest. And at the end of his speech, he asked for 5 minutes, at least, to extend for his speech. So organizers allowed him. He told about Dr. Somraju sir. He is an example of doctors. So I am proud to be his student because I probably Dr. Somraju sir knows or not, I don't know. But this to the gathering of more than 1,000 neurophysicians and the national and international speakers there, Dr. APJ Abdul Kalam lauded Dr. Somraju sir for his devotion and for his dedication to the medical fraternity. So with this I close. So probably I have given my own thought process. Thank you. Thank you, Anup Agarwal.
Thank you so much, Dr. Shankar. And I think certainly their words of wisdom. I'm muting you so that we don't get any cross noise. As I started by saying that because the topic is a little bit offbeat, we are certainly going to have some tangentiality. So for the sake of discussion, we'll discuss about, so one thing is adding value to a patient experience who came to see you. And the other thing is adding value to a community as a healthcare provider. And I think those are different topics, and certainly we can talk about how to add value to your community, how to add value to your society as a doctor. We'll restrict our discussion to how to add value to a patient who comes to your OPD, and in terms of how to get that. I'm reminded of what happens in villages where, because there is no specialist culture, where there is one doctor who pretty much is a neurologist and a physician and a cardiologist and everybody. So there it is quite a common view where the entire family comes and the doctor sees the husband, the wife, the uncle, the grandfather and the kids one by one. So that way, for their time, the doctor adds value by pretty much seeing every single person of the family. Something akin of this, what I'm thinking is a patient comes to us and patient typically come with their own attendants. And if there is a 62-year-old guy with MI, I certainly can talk, if he comes with his son, about primary prevention of ASCVD to his son. And for that, the son doesn't need to be registered or pay me or anything. That's a gesture that I can show, just so that there is added value to the index patient's visit. Similarly, Dr. Shankar mentioned about the staff ancillary help that we can provide to the patient in terms of social worker, dietitian, or whatnot. I never thought of asking patients for getting a health insurance after the event. I don't think I have ever discussed that. This is something that I'm thinking that why I never did it. I probably should start discussing it now. That when a patient comes to me, who for his index procedure paid out of his pocket, to talk to him that, hey, why are you not taking health insurance and how can I help to get you the health insurance? Similarly, I also think that educational material, either verbally or giving a physical handout that person can take home, read, study, all those kind of things, or people whom you have in the OPD who can teach them how to take their blood pressure at home, what kind of exercises they can do, and all those kind of things. I think they all come as a part of this patient experience. And of course, what Dr. Shankar also mentioned, I'm just summarizing what he said, to tell them where to find cheap medications and our own knowledge base to tell the patients that which brands are reputable, which you can take, and which brands or which names probably are less reliable. So even if they are cheap, patients can avoid them. So even dispersing that knowledge to the patient certainly adds value to it. I'm going to continue the discussion with more thought process. Dr. Srinivas, if I can have your thoughts of how you add value to the patient who comes to your OPD, who otherwise is not having an MI where you are diagnosing ECG, who is otherwise fine, where the OPD visit would pretty much finish in 2 minutes. How do you add value to your patient's visit? Dr. Srinivas.
I think Dr. Shankar has already touched upon the subject elaborately, but in addition to what he has already discussed, since it's been 1 year since he had an acute coronary syndrome, probably we can cut down on dual antiplatelets, and depending on the bleeding risk or further thrombotic risk, we can give him one antiplatelet, and the dose of statins also we can cut down. And even though he doesn't have symptoms, we should still find out about his habits like intake of alcohol, habits like smoking, his dietary habits, and then help him with the dietitian's consultation. And then future events we should prevent for that patient. And yes, as suggested, health insurance, we should insist if they don't have it, then they should probably go in for a health insurance rather than having it little later, because once they cross 65, 70, I don't think they get a health insurance. So if at all they should plan little early, otherwise probably little later, even health insurance also, they wouldn't be able to access it if they go in for insurance little later in life. Yeah, that's all.
Perfect. Yeah, perfect. Thank you so much, sir. I also wanted to share, so one of my seniors from AIMS who currently runs a primary care office in Gurgaon and Delhi NCR region, he was sharing with me how he adds value. He was supposed to join us for today's visit, for today's discussion. For some reason he didn't. So he used to share with me that, Anup, the way we add value is that, let's say if a kid comes for his 5-year vaccination, typically kid does not walk in alone. Typically he or she comes with his parents. So any kid who comes for vaccination gets a growth chart tabulated, gets future vaccination table made. Every person who accompanies him gets a free blood pressure check. And if things be right and if they're free, they even get a random sugar check and whatnot. So what he says is these are his ways how he adds value, and the same thing goes for the other way around. If a adult comes for checkup with his kid just accompanying, then the kid gets a growth chart documented and their vaccination schedule documented just without asking. That's like a reflex thing that they do to so-called add value in patients' care, and of course with the ancillary staff who can educate them about what else. Other very important thing, this is something, and Dr. Somaraju has been quoted multiple times. I'm quoting him one more time. I have quoted multiple others as well, so at least I'm not biased to one person. So I remember one time where I was presenting a patient to Somaraju sir, and it was an open and shut case. All Somaraju sir had to do was say hi to him, and that was pretty much it. I thought, what more value is going to be added? I'm talking about 3 some years before. And the whole discussion goes towards what car you drive and what time you drive. Do you drive or do your driver drive? And it all comes down to accident prevention and whatnot. And then you realize that even that is pretty important for a patient's health care, because God forbid if he gets an accident because of all this, what would our excellent heart health would do to him? So as a cardiologist, why not talking about accident prevention or suicide prevention or whatnot for that matter? Of course, time is a constraint. We can talk about all this in theory, but how to put it in perspective, how to have a systematic way so that when patients come, they automatically become a beneficiary of this kind of value addition. So having said that, I open the discussion for anybody who has got any thoughts or questions or anything to add. Please unmute yourself and share your thoughts. Praveen, you have something to add?
Yes, sir. I have something to add, sir. Can
Please
I speak, sir?
Yes, please go ahead.
Sir, the other things for the patients who come from a long distance and they're having the financial constraints, or they need a particular doctor in case of some need. Say, for example, the present COVID vaccination, the concerns regarding the stoppage of the antiplatelets and all that. Say, for example, one patient tries to call one of us, and we might be engaged in some of the cases. So most of the times they call us 3-4 times and they think we are busy. We should be having what you call one facility where they can leave a voice message that doctor, I am so and so, I am calling regarding this one. Whenever you are free, what you call please clarify my doubt. That would be helpful for them, and that we are there to clarify them. Some of them will be keeping the WhatsApp messages, but most of the time we, what you call in our busy schedule, will be not viewing the messages. So voice message would be fine. And if we give our contact number, say for example, if we have any assistant, those patients who are on regular follow-up and are coming from a long distance, just having a conversation with them 2 days before their prior visit would ensure that we are also concerned regarding their well-being. That is what I want to say.
Perfect. Thank you so much, Praveen. And I think that some of this goes to our own principles in terms of how we want to manage our OPD. Like I by principle do not want to entertain unsolicited patient phone calls. I just don't want to. No matter whether what kind of scenario it is, what time of the day it is, I don't want unsolicited patient's phone call. But at the same time, I agree with you that patients need to have a way to reach out to you. If they don't have a way to reach out to you, that patient-doctor relationship is broken. So what I have found out a middle ground is I give them a WhatsApp number. That WhatsApp number does not have an incoming facility. That WhatsApp number only has a WhatsApp facility. And I tell them, if you have any query, either you WhatsApp me there, and I understand there are many patients who cannot type. So I teach them how to record their message on WhatsApp and send it to me. So it's almost like that voicemail that you were, or voice message that you're talking about, that rather than typing their message, they just put up the audio button, they say whatever they want to say, and then it comes to me as a message, which I check it later whenever I'm free. So doctors who are willing to take unsolicited patients' phone call, good for them. They should continue to do it. I find it too much interruptive in my daily practice. So I have established this kind of channel. I agree with you that some sort of channel needs to be there. If there is no channel, the moment patient leaves your OPD, if he or she does not know how to contact you, I think that's a disservice that we are doing. But having said that, keeping your phone line open 24/7, personal phone line open 24/7, that I think is too intrusive, at least for me. So I don't do that. Anyone else has got any other thoughts before I ask Dr. Somaraju to share his opinion? Any questions or any thoughts about this thing? Dr. Shankar?
This concept is very new and it is very much fascinating to me. One thing I want to tell and close. We are just on this platform, we are coming together and meeting together. It's a beginning and it is a valuable experience for me. If you work together for the value-based care, it will definitely bring about success, and it closes the gap between the patient and the doctor, and the doctor will be again considered as a Vaidyo Narayano Hari. He is equal to God. Thank you.
Thank you so much, sir. I will share two more anecdotes and then we'll move to Dr. Somaraju for his comments. So I was amazed to know that even in tertiary hospitals in US or universities in US, they still have midwives when it comes to obstetrics care. And a lot of patients, they get treated by midwives. So they are in the hospital, they are employed by the hospital, they are not doctors. They are your traditional rural midwives. And I always thought that, okay, even if in US you have midwives, they are probably there in the rural area, but I was proved wrong. Even in big hospitals, they have midwives. Similarly, this whole concept of nursing practitioners, these are the nurses who have got a license to practice as a primary care physician. So they call themselves as NP or nurse practitioner. They kind of take over the role of primary care physician. They end up being the liaison between the patient and the specialist. Some of these nursing practitioners and these midwives who are currently one of the main healthcare providers in US system, it kind of brings the point that why we need these mid-level providers. And one of the reasons is because they are adding value to patients' experience, which physicians or doctors or specialists are not able to add. And I'm not saying that they are smarter than doctors or doctors are smarter than them. No, it's not a comparison statistics. It's about how much effort and energy and whatnot a patient spends to go and see a doctor and what kind of value he gets out of it versus what he needs to do to see a nursing practitioner or a midwife and what kind of value he gets out of that experience. So if he doesn't have to wait to see a nurse practitioner is willing to spend half an hour with that patient for a routine cough as compared to waiting for 2 hours for a physician who also does a good job. I'm not saying that either of the two is doing a good job or a bad job. For a patient, the perception of value is far more when he or she goes and visits a nursing practitioner or a midwife for that particular aspect. Now, of course, that can't be scaled to everything, but certainly it has got its role. And it does give us this feedback. Us as physicians or specialists, it gives us the feedback that we should be constantly working on making sure that we add value to our patient's experience. If nobody has any thoughts, may I ask Dr. Somaraju from here on, from 8:22, if you could take the rest of the time and share your thoughts about this and some kind of guidance in terms of how we should incorporate this in our daily practice. Dr. Somaraju, sir.
Thank you, Anup. And I must tell you, and some of you said something, certain things good about me. I hope I deserve all that, and then it's an unending game, and the challenges are enormous, and I'll leave it at that. And while saying this, today's say inpatient care in tertiary care medicine, outpatient care cannot be done in isolation as a single clinician. It has to be a teamwork. The team involves not only just doctors or a senior clinician, one of us, but another colleague of yours or more while they rotate, and also a student who is training in the specialty you are training them. And because more and more care is moving towards outpatient area than inpatient now. So the students should be trained right from the beginning of their careers. So I used to insist upon a DNB student spending time with the senior clinicians by rotation. And then when you say the team, it's not only doctors but also nurse clinicians, and physician assistants, nutritionists, psychologists, and one of the nurses by rotation. Somebody was talking about the problems of INR and all that. One of the nurses is always in charge of some of the areas. And to the extent that over a period of years, I started this idea of teamwork in the outpatient area, making sure that many of my patients are also seen apart from me. One of my colleagues, it may be junior, but over a period of time, many of my patients feel comfortable going to them and talking to them and following with them. And I lose a lot of patients to my colleagues over a period of years. But that's what medicine is about. They are not. So in other words, you can't take care of everybody over a period of years. And the teamwork helps us. And also train your students. Many of you are senior enough people. And then while you run your outpatient, request your junior colleague, either a consultant, junior consultant, or a DNB student or a DM student, be part of the outpatient you run. They must watch you, how you perform, and they will learn slowly. And that's how we can improve upon all these things. And none of us can do this alone. It requires teamwork. And some of you watched me doing what I was doing at care. And we never refused a patient because this patient cannot afford routine charges. We had two varieties of charges in the outpatient, routine outpatient and general outpatient. No patient is refused just because they couldn't pay. And same thing applies to many other areas you do. And because I think I should not be taking away a lot of your time, I must insist the importance of working as team. Team involves not just doctors and nurses and all the people involved in it, and also training the juniors and making it affordable to people. When you say value is the quality you give versus the cost, and the care we give should keep all this in mind. And in the large number of patients you see for a hospital, whether it is corporate or something else, in numbers, we can still make it, say, cost effective to the organization and people around, and everybody will be benefited by all this. And if anyone has any specific questions, I will answer it. Particularly important is train your juniors in such a way that they will carry this forward.
Sir, at the face of it, I have two questions directly for you. Number one is, and I'll put both the questions and you can answer one by one. So one is, when we talk about the cost versus value, by cost we not necessarily, and I'm sure you know this, I'm just saying it aloud so that everybody listens to my part. Cost not only includes the money that the person is paying, but like for a person like me, or let's say a businessman who comes, for that person, spending 2 hours in the hospital is costlier than spending 2,000 rupees for 30 minutes. So for him, cost is time. There may be somebody else, for him, the cost is convenience. He doesn't want to come at 2 p.m. He wants to come at 7 p.m. So when we talk about cost versus value, we have to look at all of these aspects. So I'm just giving a contrary statement to myself, that if I put a dietitian, if I put a psychologist, if I put all of this, and I want my patients to see them so that they can express their thought process and they can educate them and all this. A patient may think that I'm spending 1 hour or 1.5 hours or whatnot because practically there won't be a walk-in in all of these rooms. The patient will probably be waiting between the two rooms to go and talk to somebody. So for a patient's perception that why am I spending 1 hour or 2 hours for a 5 minutes doctor's FaceTime? So that is one so-called cost to value, which I often struggle to figure out how to make it compatible. That is one. And second, while educating student is very important for us, and I think as a general it will help the healthcare, there is no doubts about it. But when we look from the patient standpoint, for most of your patients, do you think they perceive this as a value addition where they go and see a junior staff member of yours first and then come and see you? Do you think many of the times they perceive it as a value addition, or they perceive it as an extra burden, which is a mandatory thing for them to be able to see you? It's like a price they have to pay to come and see you. What do your patients typically perceive in that? So those are the two questions that I have for you, and then we'll ask the attendees if they have any questions. Sir.
Anup, I'll answer your second question first. When we started this idea at Nizam's Institute in 1985, people started wondering why this American method, they used to call it. And some of my colleagues also didn't agree with that more than one of us seeing a patient. And then over a period of, even some of the patients were not too ready also, but they were not even willing to see the nutritionist. We used to have nutritionists at that time, 1985. And some of my colleagues also didn't believe it. And the patients also wanted to hear everything from the senior most clinician, including the diet. But over a period of years, we insisted upon it, and then we, whoever didn't want to go through that, we complied with them and made it possible for them to read differently. But over a period of years, and all of them were benefited, because more than one of us seeing a patient, there is a safety involved in it. And not every patient you make the diagnosis right. Your colleague going through and you going through, some of the difficult issues will be brought out. And from 85 to now, the patient care issues are more complex and comorbidities are enormous. Diagnostic issues and therapeutic issues are more complicated. More than one of us seeing a patient was a great help. And you and Anup helped me sometimes in the outpatient. That was a great help to, not only to me, but to a lot of patients. I would have missed some of the diagnosis. Today, Kishore, Dr. Kishore, who helped me all along, was there in the last 22 years or nearly 25 years. And he is one of the very good clinicians, and he sometimes points out some of the things I miss. And some of the nurses who worked with me as part of the team were with me for more than 15 years or more, and they do point out certain things that both Kishore and me miss. That is the way it works. And what was your first question you said?
Sir, the first question was about the variety of costs that patients pay, both in terms of time, both in terms of convenience and money, whatever. And how do we...
Yeah. I remember now. I can tell you. We used to have 3 types of patient charges in the care when we were together. One is general outpatient, where the patient pays the least. A routine outpatient, as all of us know. And also walk-in and a special category of patients, they pay highest, not only for the consultation, but also for the investigations. They choose their own time, they choose their clinicians, they want to spend a particular time, amount only, and then they want to be seen only by somebody. They are given all that, but they are paid the highest. And then this is the way this cross subsidy helps in the society we live in. And we try to implement it. We used to call even say a patient who has multiple problems, and we used to call it simple, compound and complex consultations. The patient doesn't go to all the doctors all around. The doctors see the patient in one room and they sit together and talk, first amongst themselves, and then they talk to the patient and family together. That was the higher level of consultations. That model somehow has to be continued, but hopefully it is continuing.
Sir, do you know of any corporate hospital which is doing this outpatient complex patient visit kind of model where more than one specialist come in one room and talk to the patient? Do you know?
We used to do that in care when we were together. But I must also confess, some of the consultants, when they were approached to make a part of the team, they were not willing. The problems are not with the patient and community, the problems are with the profession also. Be aware of it.
Thank you so much, sir. And I think that we are certainly heading towards end of our time. Is there any other discussion points that we have missed? Any questions that anybody has? I'll be more than happy to address. Anybody has got any other questions?
Just
Good
one.
evening,
Yeah.
Sorry, who's there? Please unmute yourself, whosoever wants to speak.
Sir, Dr.
Good
Anup, I
evening.
just had one. Okay, sorry.
Yeah, let us go with Mr. Vijay first, then we will go with Rahul. Okay, Vijay, please.
Sure. Sir, I had just one comment. It was a very, very good discussion. Just one comment that from patient perspective, if we call the other, the additional doctors that might see the patient, if we call them juniors, then it might not inspire the patient confidence. So rather than juniors, if we call them, consultant or maybe critical team members or working with the senior doctors, I think that positioning is important. That's all, sir.
No, absolutely. I think that is very, very relevant. And while we discussed amongst ourselves with the first name and whatnot, it is a dictum that whenever we talk amongst us in front of patient, we always use doctor as a prefix and we always use colleagues rather than anything else. So be it my DNB student, be it my junior consultant, and I must appreciate that people as senior as Somaraju sir himself, but I can name pretty much every senior colleague whom I have worked with at CARE. They have all introduced me as one of the junior most consultant in CARE to their patients as colleagues. And I think this is I take pride that most of the cardiology colleagues whom I have worked with, at least they do this. They never talk in front of the patient as a junior or student or whatnot. We are all colleagues because we all add value in our own way. Definitely. Point well taken. Okay, Rahul, please unmute yourself.
Good evening, Anup. Good evening, BSR sir. I just want a point across. When sir discussed, we used to discuss what sir used to call it like a complex model, discussing, getting into one sir chairman's room and discussing the whatever. It can be a case of a catheter-directed fibrinolysis versus a systemic thrombolysis for a patient. I just remembered that case where all across the interventional radiologist, everyone is called into the room and we discuss the case. The same thing is being implied in the OP basis. What I would like to emphasize is can we add value to a patient who could be a very good academic model to us? In that way, can we give him some academic kind of system where we can add value to him and use him as academic thing for our junior colleagues or the institute?
So, Rahul, one answer to your first comment and then question for your second. So, the model that you described, that was the clinicians meet, which I think is in a standard term, it's called multidisciplinary meet. And doing multidisciplinary meet in an inpatient setup is very much doable. Having said that, we still don't do it. So kudos to people who do it. But in the inpatient setup, multidisciplinary meetings are possible. The challenge comes as an outpatient. When these patients come to your OPD, for long I'm trying to get a valve clinic set up where all I need is a cardiologist and a cardiac surgeon sitting in the same room. I'm not able to do so, let alone a multidisciplinary meeting with more than 2 consultants coming in the same room. So in our current challenging model, like what oncology has tumor board meeting and whatnot, it is very difficult in an outpatient setting to do it. Now, difficulty does not mean that's an explanation for us not to do it. And that is where we talk in these kind of groups to see how we can make these things happen, taking everybody's interest into account. We can't just impose things on. And as far as your second thing is concerned about patients being an academic model, now I can certainly see how it adds value to doctors. I don't know how it will add value to the patient. And that is something maybe somebody can educate me, like how will it add value to patient other than patient getting a sense of altruism that he's helping somebody. I don't know how it will add value to the patient per se. And here we are talking about adding value to patient.
Yeah, for your question, I'm sorry to interrupt you. Adding value to the patient. In the past, I used to get a few of the thyroid. Suppose there is a doubt of a myxedema coma. I'm just trying to extrapolate to inpatient to outpatient. So such investigations which were like part of academic model, having discussed with biochem HOD or other Shantini madam and someone, they would do investigations in academic way. I mean, not chargeable and all.
Exactly. Okay.
That is how somewhere I'm trying to extrapolate it. I would like Somraju sir to do it because I saw him doing it many times.
Right. Yeah. So we are talking about monetary incentive to a patient so that the patient participate in our academic discussion. So it's kind of win-win for both of us. I think if we can have a monetary setup, something like this, and patient should perceive that as a value. Like if for patient money is not a problem, and if it's a good academic case, he or she may not take your free lab assessment, versus a lot of our patients, they do value money, and for them it is going to be a good incentive. So certainly in that model where it's a financial incentive to the patient, it certainly can add value to them. Okay, it's 8:40. Any other comments or questions anybody has before we close the session? Okay, Praneeth, your closing comments on today's kind of off the beat discussion, and then we will be done after that.
Yeah, so I should appreciate that we could discuss this offbeat discussion. Thank you for getting this topic. Definitely worth putting a thought where at least if we can think in our day-to-day busy practice when we are just going in a routine flow, if you can kind of pause and think that how can I add value to the patient who is traveling? How can I do this thing? If you can get a thought in between, that itself is a value, I should say. And from there on, anything that we add will be worth it. And everything starts with a single step. So I think if with this discussion, if we can get this thought process in our routine practice, I think that itself was a success, I should say. And we should strive forward in trying to see how can we add value in every aspect, writing from the prescription to investigations to whatnot. And I think it's definitely a good thought-provoking session that we had.
Perfect. Thank you. And my special thanks to Dr. Shankar and Dr. Somaraju for sharing their thoughts. A lot of these comes with experience, and certainly as we go towards what Praneeth said, unless we think and work on it, it won't come automatic to us. So thank you all for participating, and thank you for your questions and comments. We'll see you again next week. And I believe next week is, and I have to say it again, if the next week is in March, then we will still do it on 7:30 p.m. We'll start at 7:30 p.m. If next week comes in April, we will start the session at 7 p.m. I will send you the invitation. It will have the time.
March session.
31st. Okay, so 31st we will do 7:30. We'll start April. We'll start 7 p.m. onwards. So next huddle we will start at 7:30. Following that, we will start at 7 p.m. onwards. So thank you all for participating. Some of the huddle episodes are there on YouTube and podcast. They are not up to date, but hopefully they will be at some point if I find time. So please, you can check on there as well. Thank you all, and if you have any other thoughts, please share with me offline as well. Thank you. Good night. Good night, guys. Thank you for joining. Good night.